Hi, this is Dr. Arpitansu, and today we're going to talk about pneumonia. This is for the BMS second year Roglidan subject, or also called as the pathology. So let's begin with the introduction first. What is pneumonia? Pneumonia is defined as an acute respiratory illness associated with a recently developed radiological pulmonary shadowing, which may be segmental, lobar, or multilobar. So basically, pneumonia is an acute respiratory illness. It is a short-term illness and not a chronic one, and related to your respiratory system. Basically, most importantly, the lungs. Pneumonia is actually an infection of the parenchyma of your lung, and it can be classified as a community or a hospital-acquired, or those occurring in the immunocompromised host. The immunocompromised host means the person who has previously suffered from some kind of infections in their lungs. Okay. The community-acquired pneumonia, also called as the CAP, is one of the lower respiratory tract infection. That is a lower respiratory tract, you mean alveolar infection. And worldwide, it continues to kill more children than any other illness. And Streptococcus pneumonia, which is a bacteria, is the most common infecting agent of this. Now, in the next slide, you can see a schematic diagram comparing a normal alveoli with the alveoli of CAP, a person suffering from CAP, which is the common community-acquired pneumonia. You can see the normal alveoli, we have normal alveolar flora and the alveolar macrophages, while in the what happens in actually a community associated pneumonia, that a person aspire a streptococcus pneumonia, which is a pathogen causing pneumonia. Okay? So when this is, person aspire the streptococcus pneumonia, it traverses through the bronchial pathways and enters into the alveoli, and in alveoli it starts multiplying profoundly. Okay? There's uncontrolled multiplication of the pathogen in the step 2. As you can see that step 1 is the arrival of pathogen in the alveolar space, and this is the streptococcus pneumonia. And in here, over here, you can see that there is a multiple streptococcus pneumonia colony forming, and this is an uncontrolled multiplication of pathogen. In the third stage, you can see in the normal alveoli there was a alveolar macrophage present, local alveolar macrophage. So this local alveolar macrophage start producing the cytokines. And in the fourth stage, the neutrophils, which was normally flowing into the blood streams, starts entering into the alveoli and produces an exudate, alveolar exudate. Okay, and also the cytokines which was released by the alveolar macrophages starts entering into the lymphocytes. Oh, sorry, blood vessels. Okay. The production of the alveolar exudate is what we call as the fluid-filled alveolar sac in the pneumonia. So this was a normal diagram or pathology, basic pathology. Now let's see what are the factors that predispose to the pneumonia. The most common cause will be cigarette smoking, old age are the more common, and upper respiratory tract infection, recent influenza infections. There are some other infections also which may lead to the pneumonia, such as the pre-existing lung diseases or HIV, alcohol consumption, indoor air pollution, or a corticosteroid therapy. Now let's see what are the common clinical features which are present in pneumonia. These are the features which are most commonly seen in the pneumonia. The first, there the patient will be suffering from a high-grade fever. There will be the rigor, shivering in the body, and the most prominent one, this prominent vomiting will be predominant. Okay, the person will have vomiting, more vomiting. There's a loss of appetite. The headache will be common, and what will be the pulmonary symptoms that will be visible? There will be the breathlessness and the cough. The cough which was the cough first will be short, which is characteristically short, painful, and dry. But on the later stage, it will be accompanied by the expectoration of the mucopurulent cough, sputum. And the sputum may be of the rust color, okay, with the streptococcus pneumonia infection. And occasionally there will be the hemoptysis and pleuritic chest pain. On patient will say that there is a the patient will refer this pleuritic chest pain as a shoulder pain or anterior abdominal wall chest pain. Okay, now let's see what are the types of pneumonia. Basically, at first we saw there were the three types of basic pneumonia: community associated pneumonia, which we called as CAP. Second was the hospital pneumonia. Okay, and the third was in the person suffering from immunity compression patient, immune compressed patients. Now we will see the two types of pneumonia other categorization. This is a typical pneumonia, and second is the atypical pneumonia. Further, typical pneumonia is of two types, Lobar pneumonia and bronchopneumonia. We will study each of them one by one. First, let's start with the typical pneumonia. Now, typical pneumonia is an infection caused by the extracellular organism, mainly the bacteria. Okay, so typical pneumonia is most commonly caused by the bacterial, so it is also called as the bacterial pneumonia, and it is characterized by the neutrophilic infiltration. Remember that it is characterized by the neutrophilic infiltration, and there is a presence of intraalveolar exudate leading to the consolidation. It is the most important characteristic of a bacterial pneumonia or a typical pneumonia, that there are the infiltration of neutrophils and there is a presence of the intraalveolar exudate. Okay, the clinical features of this typical pneumonia is a high grade fever and a mucopurulent cough, which may also be associated with a pleuritic pain. And in the untypical pneumonia, it is caused by the intracellular organisms like mycoplasma, chlamydia pneumonia, and virus like RSV, influenza, and rhinovirus. So typical pneumonia was characterized by the neutrophilic infiltration, whereas the atypical one, which is also called as the viral pneumonia, is characterized by the infiltration of lymphocytes and presence of alveolar septal. But remember, there is absence of alveolar exudate in this type of atypical pneumonia, and there is also an interstitial inflammation. Clinical features of this atypical or viral pneumonia includes the fever, headache, dry cough. Remember, in the typical pneumonia or bacterial pneumonia, there is a mucopurulent cough, whereas in atypical or viral pneumonia, there is a dry cough. Also, there will be myalgia present. Productive cough and pleural movement is uncommon in this type of pneumonia. Now, let's see a diagrammatic difference between the bacterial pneumonia and the viral pneumonia. So, bacterial pneumonia, which was mostly caused by the bacteria like Streptococcus pneumonia or pneumococcal pneumonia, and the viral pneumonia, which was caused by a lot of things. For example, presently we have seen COVID-19 also causes the viral pneumonia, and the type of immune cell which is involved in the bacterial pneumonia are the neutrophils and macrophages, whereas the type of the immune cells which are involved in the viral pneumonia are the lymphocytes. Okay, so bacteria in the bacterial pneumonia, the bacteria enters into the alveoli and begin to grow, as we have seen in the cap, and the capillary open and neutrophils come into the fight into the bacteria. We have already seen that in the cap, and there is a exudate formation which is called as the edema, and the macrophages clean up the debris once the infection is gone, and weeks later the lungs return to the normal state. Similarly, in the viral pneumonia, what happens, the virus enters the cell and begin to multiply. The cells are destroyed as viruses burst through, and the lymphocytes sense and destroy virus infected cells, and type 2 pneumocytes grow to replace the damaged cells. You can see over there is a hyaline membrane formation, and weeks later the lungs return to the normal stage also. Now let's see the subtypes of the typical pneumonia. The first was the lobar pneumonia. In the lobar pneumonia, there is a consolidation of the entire lobe, and it is usually caused by the streptococcus pneumonia. Okay, lobar pneumonia, in lobar pneumonia, the entire lobe will be consolidated. Okay, and lobar pneumonia occurs in four stages, which are called as the congestion, red hepatization, gray hepatization, and resolution. We will see to it in a minute. What happens in the congestion? Congestion, at first there is a vasodilation of the blood vessels, and there's a bacteria rich intraalveolar fluid at first in the lobar pneumonia. After that, the exudate will be rich in RBC, neutrophils, and fibrin due to the infiltration of neutrophils, and along with the neutrophils comes the fibrin and RBC. In the third stage, that is the gray hepatization, the RBC get degraded, and there is a fibrinosuppurative exudate are present. And in the fourth stage, there is an enzymatic degradation of exudate, and there is a healing. So the chest X-ray of the lobar pneumonia show a pacification of the entire lobe. Okay, so because the entire lobe was affected, so in the chest X-ray, the entire lobe of the lung will be showing a pacification. So here are some macroscopy. As you can see, this is the congestion turning into the red hepatization, and there is an exudate filled intra. You can see due to vasodilation, there is a bacteria-rich intraalveolar fluid, as you can see over here. And in the lobar pneumonia red hepatization, you can see that the acute inflammatory cells like neutrophils and RBC are filling the alveolar spaces. And over here, you can see the congested capillary in the alveolar septa. Moving on, in the gray hepatization, you will see the RBCs are getting degraded. Now, the second type of typical pneumonia or the subtype of the typical pneumonia was a bronchopneumonia. It is a patchy consolidation in the lobe of the lung. Lobar pneumonia was a consolidation of the entire lobe, whereas the bronchopneumonia is patchy. It will be present in the patches around the lobe of the lungs, and it is usually bilateral basal in location due to the gravitation of secretions. It is usually in the basal, bilateral basal present, and it affects the extreme of agents. Extreme of ages, by extreme of ages means that either it will be present in the infants or in a severe old person. Chest x-rays show the patchy of acidification. Obviously, the patch there's a patchy concentration of the lung. So in the chest X-ray, there will be the patchy opacification of the lungs. Now, what are the physical examination findings in the of the pneumonia? First, we will see that there will be the upper abdominal tenderness is sometimes apparent in the patients with the lower lobe pneumonia, or if there's associated hepatitis. Okay, proteinaceous fluid and the inflammatory cells congest the air spaces, leading to the consolidation of the lungs. We have already seen due to the neutrophilic infiltration and the lymphocytic infiltration, there is a congestion of the lungs, of the air spaces, and this improves the conductivity of sound to the chest wall. Now, because of the infiltration, the conductivity of the sound is increased, and the clinician may be hear bronchial breathing and whispering pectoraloquy, and the crackles are also often detected through the stethoscope. Okay, so what are the investigations for in the X-ray? And a chest X-ray usually provide the confirmation of the diagnosis. We have already seen that in the lobar pneumonia, a homogeneous opacity, that is the entire lung opacification, will be present to the affected lobe or the segment, usually appears within 12 to 18 hours of the onset of illness. And the radiological examination is helpful in the complications such as the parapneumonic effusion, intrapulmonary abscess formation, or emphysema is suspected. Now, next we will see uh, the microbiological test. First, uh, we will do the test of the sputum through direct smear by the Gamma and Zell Nielsen stains. Then we can also say take a culture and antimicrobial sensitivity testing. In the blood culture, we will find a pneumococcal pneumonia positivity. In serology, we can find acute and convalescent titers of the Mycoplasma, Chlamydia, Legionella, and the viral infections. Pneumococcal antigen detection in the serum and urine can be done. On the polymerase chain reaction, that is a PSR, mycoplasma can be detected from the swab of the oropharynx, severe community acquired pneumonia, that is a CAP. And the above test plus consider tracheal aspirate include induced sputum, bronchoalveolar lavage, protected brush specimen, or the percutaneous needle aspiration, direct fluorescent antibody stain for the Legionella viruses. And in the serology, Legionella antigen is present in urine and the pneumococcal antigen in sputum and blood. Immediate IgM, immunoglobulin M, is done for the mycoplasma. Cold agglutinogens is positive in 50% of the patient with a mycoplasma. A full range of microbiological tests should be performed on the patients with a severe community-associated pneumonia. The identification of the Legionella pneumophilia has an important public health implication and require notification. In patients who do not respond to the initial therapy, microbiological results may allow its appropriate modification. Microbiology also provides useful epidemiological information. Now, pulse oximetry can also be done to know whether the person is suffering from pneumonia or not. And we can also take ABG, which is the arterial blood gas, in the patient whose SpO2 is less than 93%. Okay, and fluid blood count. Okay, usually the white cell count may be normal or it can be marginally raised in the pneumonia caused by the atypical organism, that is a virus, due to the lymphocytic infiltration, whereas the neutrophil leukocytes of more than 15 into 10 to the power 9 per liter favors a bacterial etiology. Now, if there's a, you have to find that whether the lymphocytic count is increased or the neutrophil leukocytosis is present. Okay, a very high or low white cell count may be seen in the severe pneumonia. Okay, biochemical tests like urea and electrolytes and liver functioning tests should also be checked. And accused phase reactant like C-reactive protein CRPs are typically elevated. The differential diagnosis of the pneumonia, we can see if there's a pulmonary infraction, pulmonary tuberculosis, pulmonary edema can be unilateral, pulmonary eosinophilia, malignancy like the bronchoalveolar cell carcinoma, rare disorders sometimes like cryptogenic organizing pneumonia, bronchiolitis obliterans organizing pneumonia, which is called as the COP or BOOP, BOOP, COP or BOOP. So thank you for watching this, and